Good morning and welcome, everyone. Thank you for joining us to this virtual journal club. I'm JP Brito, endocrinologist at the Mayo Clinic and co-host of this virtual series. I have the pleasure today to introduce Dr. Mimi Hu. Dr. Hu will be talking about medullary thyroid cancer and updating management. And Dr. Hu is an endocrinologist, endocrine oncologist, and professor and deputy chair of clinical affairs in the Department of Endocrinology and Hormonal Disorders at University of Texas and the Anderson Cancer Center in Houston. After graduating from Rice University with a degree of mechanical engineering, she earned her medical degree from University of Texas, Houston Health Science Center. She completed her residency and endocrinology fellowship at the Baylor College of Medicine, where she also served as chief medical resident. After completion of her resident research fellowship at MD Anderson, she joined the faculty in 2007 in the Department of Endocrine Neoplasia and Hormonal Disorders. She developed and is the program director of the Oncology Endocrine Fellowship Program, which is the first of its kind, a very actually famous program for anybody who works in the area of thyroid cancer or endocrine neoplasias. This is a one-year training program to further the clinical and research experience of a physician interested in specializing in the management of endocrine cancers with systemic therapies and endocrine consequences of cancer therapy. Dr. Hu's clinical expertise is in the evaluation and treatment of patients with thyroid carcinoma, with a focus in medullary thyroid cancer and hereditary endocrine neoplasia disorders. She's a primary investigator and collaborator of multiple clinical trials evaluating various targeted therapies for advanced thyroid carcinoma. She has published articles and book chapters evaluating the management of medullary thyroid cancer, multiple endocrine neoplasia, bone health in cancer patients, and paraneoplastic endocrine disorders. Dr. Hu, thank you for being with us.
Thank you, Dr. Brito, so much to you and to the organizing committee for inviting me today to speak on the update of management of medullary thyroid cancer, an area that's quite dynamic right now. So let me go ahead and share my screen. All right. All right, well, thank you so much again for allowing me to come and again, understanding how I had to reschedule this from July to now. So I'm looking forward to having our Q&A session towards the end. Here are my disclosures. So today I'm going to concentrate more on just some of the recognition of prognostic features that can predict a poor outcome in some of our patients, and those are the patients in whom you would consider needing to initiate systemic therapy. We'll talk about available treatments, both focal and targeted treatments, and also systemic therapies. We'll try to understand areas where we would consider systemic therapy, determine the factors that influence which treatment to select, and then the recognition that there are these emergent resistance mutations that we see, and then a little look towards the future in medullary thyroid cancer, because I do believe that it's very promising. So I like to start off with a case. This is a patient of mine who presented over 10 years ago to me when he was 52 with pain in his lower back, and he went to an outside hospital, and they found this very large tumor in the L3 bone, and it was threatening the spinal cord. And so they took him to surgery, and the laminectomy excision found that this was a metastatic medullary thyroid cancer focus. He was then referred over to us here at MD Anderson, and when we evaluated him, he had a left-sided thyroid mass, multiple pathologic appearing lymph nodes on the left lateral neck, and on further staging imaging, we saw multiple liver metastases. This is one of the representative ones, as large as 2.8 centimeters. So he underwent routine testing with RET germline testing, and that was negative. So this was a hereditary medullary thyroid cancer. He underwent total thyroidectomy with bilateral central lymph node dissection with my colleague, Dr. Libby Grubbs, and his left neck dissection. And actually in him, we really had no understanding of the chronicity of his disease, the pace of his disease. And so actually I offered a short-term follow-up of his situation after his surgery. And actually, this is what happened to him over the next 10 years, where you would see calcitonin naturally just having a little bit of fluctuation, but essentially pretty stable over the subsequent 8 years. Just so you know, we had a machine assay change in 2018, and everyone's calcitonin went up a little bit, but he was pretty stable over this duration with a doubling time of over 10 years. And then even though the CEA was slowly percolating upward, the overall doubling time was almost 15 years. And radiologically, his metastatic lesions remained stable. And he was doing well without any symptoms. But because of the distant metastatic disease, I did do molecular testing on him. So we already knew that his germline was negative. But when I did molecular testing, he had the most common non-hereditary mutation of RET M918. So this is a gentleman that you definitely want to continue with active surveillance, and at the time of progression, consider systemic therapy. Now, metastatic lesions in medullary thyroid cancer are often present at the time of diagnosis, most often involving the central compartment lymph nodes in almost 80% of our patients at the time of diagnosis, but also quite a significant incidence of distant metastases to the lungs, the liver. And in the liver, remember that these lesions can be very vascular, and they could almost be interpreted by the radiologist as hemangiomas. But anytime I see a patient with liver lesions that are interpreted as hemangiomas, I will follow them, especially if they still do have detectable tumor markers, because likely these could represent metastatic foci. And then the bone metastases can be seen as well. And luckily in this situation, the brain can be seen, but it's rare. Unfortunately, when we have distant metastatic disease, there really is no curative option available, despite all the systemic therapies that we have available and that I'll discuss. Now, we know that disease-specific survival will decline with advanced stages of disease, but overall, with medullary thyroid cancer, the disease-specific survival is pretty good at 8.6 years, kind of reflective of the case that I presented to you a few slides back. With localized disease, the 10-year survival is very good at 95%. With local regional disease at presentation, the 10-year survival estimated at 75%. But in the setting of distant metastatic disease, it's 40%. Now, what are other prognostic factors that we need to consider this other than stage? And doubling time is something that we're all well aware of. This was a very nice meta-analysis that pulled together a few studies and looked at calcitonin doubling time as well as CEA doubling time. And here on the left, you have the graph for the overall survival. On the right, you have recurrence-free survival. And the red bar are the patients who had doubling times less than or equal to a year. The black bar is the doubling times greater than a year. And it's clear that the patients who had doubling times that are short, less than a year, have a worse 10-year survival, 18% compared to 95% in the long doubling time patients, and also a lower recurrence-free survival, 20% at 5 years, compared to those patients with a long doubling time where it's 73%. Now, it was seen that even with the CA doubling time, it was a better predictor of overall survival and recurrence-free survival. It has a lot to do with the fact that the calcitonin does have a lot of variability. But what was interesting last year was this publication that was a very nice multi-center study looking at the pathology at the time of surgical resection. It included centers in the US, Australia, and also in Europe. And essentially, they were looking at the pathology to look at various features to grade the tumor. And it was a two-tiered grading system, low grade and high grade. And high grade was defined as having at least one of the following. a mitotic index greater than 5, a Ki-67 that was greater than or equal to 5%, or tumor necrosis. And the findings of almost more than 300 patient specimens was very reflective of how our clinical practices looks. More than 75% had a low-grade tumor, and 25% had a high-grade. Essentially, most of our patients do well, but there is that fraction that tend to have more aggressive disease. The high-grade tumor patients typically were male, had a larger primary tumor, had a higher postoperative CEA, had evidence of distant metastases at presentation, and had vascular invasion. And I know that these graphs may seem small on your screen, but as I walk you through it, here on the left is looking at overall survival. The second panel to the right of that is disease-free survival. Then we have local regional recurrence-free survival, and distant metastatic-free survival. And the red lines are the high-grade tumor specimens, and then the blue lines are the low-grade. And it's clear here that you see that the patients who had high-grade tumors had a lower overall survival, disease-free survival, local regional recurrence-free survival, and distant metastatic-free survival. But look at the x-axis here. This is in periods of time of months. So we're looking at 100 months here. I mean, the follow-up period, we see a drop-off at 50 months, but overall still, even in the setting of aggressive features, longer survival for these patients. So in our patients, what do we mean by active surveillance? And I also implemented a little something of what I do. So in 2015, the ATA published its most recent guidelines on medullary thyroid cancer. And there's a beautiful figure that kind of gives a recommendation of how to survey these patients. But something that I would implement is around 3 months after surgery, I check a lab test for a calcitonin CEA, and that's just checking for their nadir, because calcitonin CA do have a little bit of a longer lag after any kind of intervention. So checking monthly is going to be a little bit premature and actually just anxiety driving for our patients. So I check one at 3 months to kind of see where they kind of settle down after their surgery. But then there's another check at 6 months. And the purpose of this 3-month one is to compare with the 6-month test, because at the 6-month one, I'm starting to see a little bit of progression that's indicating maybe a little more aggressive behavior. But then the guidelines recommend every 6 months after surgery for approximately 2 years. And then with calcitonin CA, ultrasound of the neck, and any other dedicated imaging of other sites like the lungs or abdomen, if by chance you had baseline imaging that suggested metastatic disease, or you were following some non-specific but suspicious lesions, or there's rising tumor markers and you're suspecting metastatic disease, there's a recommendation to add on an MRI of the spine if the calcitonin is over 150. And so then based upon this, I can now calculate a doubling time. And it's best to have at least 2 years worth of data to make the doubling times a little bit more reflective of what our patient's situation is. And then if their doubling times are long, I will actually start seeing my patients once a year, sometimes even some patients every 18 to 24 months. Now, something that's not well published, but it's well accepted in our field, is that when patients have a low calcitonin but a relatively higher CEA, this suggests a poorly differentiated disease, especially in the setting of metastatic disease. So those patients who have that low calcitonin CA ratio, I follow them a little bit closer, or am just a little bit concerned about the potential for metastatic disease if I don't already know about it, and I'll be following them pretty closely. Now, in our patients who do have metastatic disease and you are concerned about either risk for further progression, or you're actually seeing some oligo progression, what do we have available for our patients? So radiation therapy has been used for a long time. And traditionally, there was this thought that if patients had a significant burden of disease in the neck, that thought that radiation after surgery could decrease their risk of recurrence. Now in the age of systemic therapies and some therapies that can also convey some anti-angiogenesis, and given that there might be risk for fistulas like TE fistulas, or and just radiation potentially leading to long-term consequences with esophageal strictures and other symptoms, we really recommend conservative use of radiation therapy in our patients after compartment-oriented surgery in the neck. And this is based upon the idea that we're really not seeing overall survival being established or improved with this treatment, and then the long-term consequences. And actually, we have some data from our institution that the radiation to the neck doesn't necessarily correlate with improved local regional recurrences nor improved survival. Now, in the situations where patients have oligoprogressive metastases in the soft tissues like mediastinal lymph nodes, or in a particular area in the lung that might be at risk for having some local regional compressive issues, or in the liver and they have some symptoms such as diarrhea, which is quite common in our patients with medullary thyroid cancer, we could consider focal radiation therapy. Also, in our patients with bone metastases, especially if they are at risk of threatening the spinal cord or causing pain or risk for fracture, considering radiation to those patients as well. And then in our patients with bone metastases, considering bone modifying agents like zoledronic acid or denosumab. And then in some of our patients, this is based upon our experience with hepatocellular carcinoma, is the use of radioembolization or chemoembolization. And I see this as a role, especially in patients who may have significant diarrhea from their burden of disease. Oftentimes, these are patients with significant liver metastases, or if for some reason there is a hope to maybe push off systemic therapy, either the patient has comorbid conditions that are not optimal for systemic therapy, or there are some other extenuating circumstances. So transarterial chemoembolization with doxorubicin has been used, but also the radioembolization with SIR-Spheres Y90 has been found to be very effective in stabilizing disease in some of our patients. And so I'm going to show this video of, I'm going to show two videos of a couple of patients who have had Y90 for their liver metastases. And these videos were supplied by our colleague in interventional radiology, Dr. Mavash Armin. And I thank him for these beautiful, beautiful images and reports. He does this routinely, where he will email us with the video clip of how our patients do after getting Y90. So this is a patient of my colleagues, Dr. Ramona Dadu, who had a RET deletion, sporadic medullary thyroid cancer, and was on systemic therapy, and actually doing overall pretty well. But there was one lesion that was progressing. And so the decision was to target this with Y90 radioembolization, and then maintain the patient on systemic therapy given overall clinical benefit. So let's see if this works. So that's one example. Then this one is a patient of mine who just came through a couple of weeks ago and received her Y90. So this is a young woman with MEN2A with a 634 mutation. And she had refractory diarrhea. And despite all the medical therapies that we can offer her, it was really hindering her quality of life. She's a postal worker, standing up, going, walking, the neighborhood, delivering mail, and she was having difficulty maintaining weight. for various reasons, didn't want to start systemic therapy yet. And so the thought was, given the very indolent progression but burdensome disease in the liver, the consideration of radioembolization. So I'll show you the video here. So we hope that with some follow-up, long-term follow-up in this patient, I'll also see some stabilization and most importantly, some clinical response with her diarrhea. Now, outside of our focal treatments, what do we have for those patients in whom, unfortunately, we're having more evidence of progressive disease? It's not just oligometastases, but it's more widespread. And it's really targeting oncogenic pathways and specific mutations that we're identifying in our patients. Now, similar to other malignancies, solid tumors, VEGF, or vascular endothelial growth factor mediated angiogenesis, is a very important driver and mediator of disease progression and metastases. So the premise is that these small tumors are exposed to a very hypoxic environment, and with that stress, it leads to increased VEGF secretion that will lead to neovascularization and allowing more of vasculature feeding the tumor, allowing nutrients to go to the tumor, and also a conduit to spread to other areas. That's kind of my basic way of thinking about this. And in thyroid cancer, both differentiated, anaplastic, and also medullary thyroid cancer, we do see VEGF and VEGFR overexpression. Now, in medullary thyroid cancer, we all know that germline RET mutations are seen with the hereditary syndromes of MEN2A and MEN2B. But in the non-hereditary patients, we also see somatic mutations, or the non-hereditary mutations of RET and also RAS. And RET is seen more often in the non-hereditary situation, almost 45%, followed by a mutually exclusive mutation of RAS in about 15%. And when you take all comers, then both the hereditary and the sporadic MTC patients, more than 60% will harbor a activating RET mutation leading to a constitutively active RET receptor. Now, I wanted to bring this up as an important point to emphasize that RET mutations in medullary thyroid cancer are activating point mutations or deletions that we're seeing rarely now, but they are not rearrangements or fusions that are seen mainly with non-small cell lung cancer, even papillary thyroid cancer, or other solid tumors. And I say this because I've had some patients refer to me saying that, yes, they have no hereditary, their germline RET test was negative, and they have no somatic RET mutation. And when I look at what mutational testing they usually did a FISH, or a fluorescence in situ hybridization test, and they said that there are no RET rearrangements or fusions. Well, that's different from what we see in medullary thyroid cancer. And when you do another test with next generation sequencing, you might identify a RET activating mutation. So just be aware of the test that was done to evaluate for a RET alteration. Now, in our patients with thyroid cancer in general, there have been multiple multi-kinase inhibitors studied in clinical trials. And this is a listing of all of them on the left and all the various kinase receptors that they're targeting. And very importantly, VEGFR2 is the one that's really the most important, contributing to angiogenesis. But you see that it targets a lot of, these drugs target a lot of other kinases like RET, BRAF, RAF, RAF, and EGFR, platelet-derived growth factor receptor. And this is what leads to this wide spectrum of side effects that we can see when patients are treated with multi-kinase inhibitors. Now, what you see here on the upper left in the green are the agents that are FDA approved for thyroid cancer. The ones that I have boxed off, and cabozantinib and vandetanib are the ones that are approved for medullary thyroid cancer. And you can see that there's a wide variation of the IC50 targeting various kinases. The smaller the IC50, the more potent it's targeting that. And thus you could see varying activities and even side effects. And these side effects can limit our patients' tolerance to these drugs for a durable period of time. These are the phase 3 placebo-controlled studies that led to eventual FDA approval for vandetanib on the left, cabozantinib on the right. And on the left with vandetanib, the yellow is the placebo patients, and I'm sorry, the blue is the placebo-treated patients, the yellow is the vandetanib-treated patients with a very good predicted response of 30.5 months progression-free survival. On the right, you have the cabozantinib-treated patients in the blue, and the yellow are the placebo-treated patients. Now, there are some differences between these trials that people should remember. The vandetanib study, the patients did not have to demonstrate progression prior to coming onto study. They just had to have measurable unresectable disease and a calcitonin of greater than or equal to 500. Cabozantinib trial, the patients did have to demonstrate progression within 14 months of enrollment. So you really can't compare these two studies directly with each other or take any indication of whether one drug is better than the other from these clinical trials. Now, with these trials, although we do see a good effectiveness for our patients with metastatic disease, there are some concerns or some issues. And one of the biggest things are the side effects that we can see. So I have listed here the reported common adverse events with cabozantinib and vandetanib here. And what we see is very commonly patients can have diarrhea. And that's an unfortunate situation in our MTC patients because diarrhea is already a known problem with the disease. So you really do need to get on top of the diarrhea, maybe even before starting systemic therapy, and then be really aware of how they're doing when they're on therapy. Additionally, we have a little more mucositis or stomatitis with these patients. It can lead to taste changes and a lack of appetite, nausea, weight loss to a significant degree. Then we can have rashes, mainly the hand, foot, or seen with cabozantinib is quite prominent. In vandetanib, we don't see as much of the hand-foot syndrome, but we do see kind of a rash, which is the erythematous rash that may not be pruritic, but then also an acneiform rash that can be problematic on the chest or in the face. We can also see hypertension in these patients about a third of the time. And so these are the side effects that can be limiting to dosing that is more effective for control of their disease. And our patients do have what I would call chemo fatigue, where if they've been on their therapy for many years, they get really tired of all of these side effects. Now, beyond that, we can also see resistance. And these are, I'm going to show you this study that was published years ago that looked at the gatekeeper mutation of RET V804 as conveying resistance to vandetanib. And actually, there was also findings that the 804 mutation also conveys resistance to cabozantinib, and recent report of a I788N RET mutation that can convey resistance to both. And what you see here on the left panel are cell lines that harbored the C634 mutation, or 804L or 804M. And when exposed to vandetanib, then called ZD6474, at increasing doses, you see very nice decrease in residual tumor activity with the 634 cell line, but not so much with the V804L or V804M cell lines. And here on the right, you see that the IC50 is significantly higher in the cell lines that harbor that V804 gatekeeper mutation. This is a cartoon that I like to just kind of emphasize why these mutations can convey resistance to the multi-kinase inhibitors, but also how RAS is a bypass mutation that can allow for patients to still progress despite getting their kinase inhibitor. So here on the left side, you see the ATP binding pocket in which the multi-kinase inhibitor typically will bind to and try to prevent cell activation and tumor growth. But with the 804 mutation, it's actually blocking the kinase inhibitor from latching on to that binding pocket and mediating the anti-oncologic effect. With the RAS mutation, the kinase inhibitor can still bind into the ATP binding pocket, but now if there's a RAS mutation, it's going to still allow for this other pathway to allow for cell tumor growth. So we now have the recognition that RET is quite an important driver in medullary thyroid cancer, but also in papillary thyroid cancer, with RET fusions seen in approximately 10% of those patients, maybe even higher percentage in patients who've had radiation exposure. Non-small cell lung cancer, we can see a RET fusion in 1 to 2%, and in various other solid tumors and even leukemia, we can see RET alterations as well. And the clinical trials have been very remarkable with RET specific inhibitors, selpercatinib and pralsetinib. And here on the left, you have the waterfall plots for the patients with medullary thyroid cancer who had previous exposure to cabozantinib or vandetanib on the left, treated with selpercatinib, and on the right here, treated with pralsetinib. And in the bottom panels, the patients who were naive to any systemic therapy previously, and very nice objective response rates of 69 and 60% in the patients who have previous treatment with cabozantinib or vandetanib, and 73 or 71% in drug naive patients. And it was just these patients were also telling us that they were feeling so much better than when they were on cabozantinib and vandetanib. And I'll tell you the anecdote that my patients literally came to me and said, "I think I'm on the placebo." And I said, "No, there is no placebo. You are actually on the active drug." And we would see diarrhea resolving within a week of starting therapy and tumor markers declining within a month. So very remarkable responses. And we had updated data presented at ESMO last year and at ATA last year, where after more patients were enrolled, still showing very nice responses of over 70, 50, 80, 70%. And also looking at duration response, we either have not reached those or they are very long duration responses over 2 years. Progression-free survival in the previously treated patients was 34 months with selpercatinib, not reached in the drug-naive patients, 25 months in the pralsetinib treated patients. They've had cabozantinib or vandetanib before, or not reached in the naive patients. So this led to, in 2020, approval for selpercatinib and pralsetinib for RET mutated medullary thyroid cancer, RET fusion non-medullary thyroid cancer, and RET fusion non-small cell lung cancer. And last year, around this time, it received indication for approval for any solid tumor that harbors a RET fusion. Now, notably, just a few months ago, the sponsor ended up removing the FDA approval for pralsetinib for the RET mutated medullary thyroid cancer. This was based on the fact that they did not feel like it was feasible to perform the confirmatory phase 3 trial that was required for showing that the agent was better than other first-line therapies. And it was not based on any safety or efficacy concerns, so this is no longer approved for RET mutated medullary thyroid cancer. Now, this is a table including the side effects for pralsetinib and selpercatinib. And as I said, our patients often say that they're not having any issues, but if there are side effects, we can see dry mouth in almost 40% in patients treated with selpercatinib, 12% in pralsetinib treated patients. We can see low white blood cell count or low neutrophils in pralsetinib, but I've also seen it with selpercatinib as well. We can see elevated liver enzymes in 20 to 30% of patients, and thus monitoring for those lab test changes is important in our patients. And then we do see hypertension with selpercatinib and pralsetinib to similar rates as vandetanib and cabozantinib. So I always counsel my patients to check their blood pressures on a daily basis when they're first initiated on therapy. There is a phase 3 trial looking at selpercatinib in comparison with standard of care, cabozantinib or vandetanib in our drug-naive patients. So what is remarkable about the study is that this is the first phase 3 study that is comparing active drug, the study drug, to other standard of care drugs as opposed to the placebo-controlled trials with vandetanib and cabozantinib. And these patients were randomized in a 2-to-1 fashion to selpercatinib, or the physician's choice of cabozantinib or vandetanib is randomized to that arm. And as of a few months ago, 291 patients were randomized at more than 21 countries and more than 150 sites. With this, it's currently under enrollment is paused at this time for a pre-planned interim analysis. And I'm sure many of you all had seen that there was a news release recently that there was indication that selpercatinib did have greater efficacy compared with standard of care. And these data will be released at hopefully at ESMO and also published soon. So in our patients, if systemic therapy is warranted, which one would you choose? And I really base it on what underlying mutation the patient has. And if you don't already have it, you might want to consider biopsying the progressive lesion and evaluating for RET or RAS mutation. And if they are RET positive, I would recommend a RET inhibitor. I think that there's a lot of effectiveness, less side effects, and we're seeing a very nice responses. If they're RAS positive or they're wild type RET or RAS, then we would consider cabozantinib or vandetanib. And our patients do well on those agents as well, as long as you are on top of those side effects. I've had a patient on vandetanib now who's been on therapy for longer than 11 years. And she's learned to live with her drug, and she's she actually doesn't want to go onto the RET inhibitor because she actually likes knowing what to expect on her current agent. Now, even with these RET inhibitors, we are seeing some issues with emergent resistance that is causing them to lose responsiveness to their current RET inhibitor, either pralsetinib or selpercatinib. And this is a study that was published a few years ago from our group, where this is a patient actually of Dr. Naifa Busaides, my colleague, who actually had a non-hereditary medullary thyroid cancer that harbored a RET 918 mutation and then had emergent V804M and V804L mutations after 6 prior lines of therapy. And the patient was enrolled onto the RET inhibitor. And what you see here on the right are the calcitonin and CA trends prior to coming onto the RET inhibitor. And then once the patient was started on selpercatinib, a very nice decline in both calcitonin and CEA. The patient was started on a low dose initially. And what we saw was that by looking at liquid biopsy, looking at cell-free DNA for various mutations, saw that the 918 and the 804 expression decreased significantly. But you see here in this green line, a emergent 806, a Y806 hinge mutation. And at this time, time, the calcitonin had popped up. So the patient's drug was increased because it allowed for a dose increase. And when the dose was increased, you saw that 806 expression declined, tumor markers declined again. And at about 2 months, there was regression of disease, and patient had a overall best response of 60% partial response. Over time, at around this 250-day mark, you start seeing a little bit of increase of the 918 and the 804 again, but the patient is still doing well. Tumor markers are responding and lesions were still relatively stable. But then at around prior to day 500, you start seeing this red line, which is the V804L increasing. But at day around 500, in addition to the 918 and the 804L, now this orange line, which is a G810C, which we consider a solvent front mutation, is starting to pick up and starting to correlate with some tumor markers progressing. And actually now at around 750 days, really increase of the 918, but also a significant rise of that G810C, the 804M, and actually eventually we saw these other mutations of 806N and 810S increasing, and the patient did demonstrate radiologic progression. And what was interesting was that the liquid biopsy with the cell-free DNA actually saw these rising resistance mechanisms prior to radiologic progression. And with the collaboration with some of our bench researchers, they looked at cell lines that harbored a 918 mutation, a cell line that had both 918 and 804, had 918, 804, and the added G810C, or an 810S mutation. And what you can see here is in the 918, very nice response with selpercatinib with a very low IC50. If it had the dual mutation of 918 and 804, a little bit higher IC50, but still responsiveness. But once you got those added solvent front mutations, we saw significant increased fold of the IC50 with less responsiveness. And this is a the diagram showing what area does the pralsetinib and selpercatinib bind. So I have here is the ATP binding pocket of the RET receptor. And this red box basically is the 804 gatekeeper mutation. And multi-kinase inhibitors, what they do, like vandetanib, cabozantinib, is they occupy this binding pocket by latching onto the front and the back end of this receptor. But they have to do that by crossing through this 804 channel. And if there's a gatekeeper mutation, they just can't lock in going through that space. So selpercatinib and pralsetinib, they bind by docking one end into this front cleft and then kind of wrapping around and then latching onto the back end. And so they can get past this gatekeeper 804. However, when you have these solvent front mutations, such as the 810S, 810C, or 810R, you're actually kind of like just blocking the RET inhibitor from latching on to that front cleft. And then if there is this, what we call hinge mutations, then, or this 738, it's actually also preventing it from locking in. And our collaborators show that the IC50, when cell lines had these mutations, the IC50 was significantly higher. And in our patient that I showed in that prior slide, the MTC patient and another patient that had a non-small cell lung cancer, these alterations were seen, and thus it led to them not responding to their RET inhibitor any longer. Dr. Hadou from France also presented data last year at the ATA on resistance mutations that emerged in MTC patients who were treated with RET inhibitors. So this was a retrospective study of 47 patients who were treated with a RET inhibitor. And of those 47, 18 had to discontinue drug therapy, 12 for progression, 4 for death, and 2 for toxicity. And of those 18 patients, they actually had pre and post evaluation for molecular profiling. 10 of them had this testing, and these are those 10 patients. And of these 10 patients, 8 of them developed new emergent mutations, and they all had progression at the time of drug discontinuation. And what you see here is the bypass mechanism of KRAS seen in the patients with the yellow, and then also the solvent front 810 mutation, and also a hinge mutation. This patient number 9 had multiple mutations. Only 2 of these 10 patients did not have any new emergent mutations. There is a phase 1 trial that's looking at a next generation RET inhibitor called LOXO-260, which targets not only all the RET mutations that we're aware of, like 918 and 634, and also the gatekeeper 804, but it also was designed to try to target the 810 solvent front mutation. And this trial is currently enrolling at multiple sites. Now, in terms of the future, I do believe that there is a role for neoadjuvant targeted therapy to optimize surgical resection in some of our patients who present with very bulky disease at presentation, or they have progression and it's in very difficult locations, or involving very important structures. And how can we help these patients? And with the collaboration with Mark Zaffario and other colleagues in our center, we've found that this was a case that was presented a few years ago at the Head and Neck Society meeting, where this was a patient who had a RET deletion, non-hereditary MTC, who at baseline, their tumor in the neck was quite advanced. And this little red dot is the blood vessel, the artery that is more than 180 wrapped with the tumor. And here's a blood vessel, and here's a tumor right up against the aorta. And although standard therapy would be surgery, this could be a very highly morbid surgery. And because of the RET deletion, the patient was started on selpercatinib, and there was significant regression of disease seen here, and it led to a surgery that was less morbid for the patient. And we went on and studied this in 3 other patients who had, this is that first case, but the 2 other patients, one that harbored a somatic 918 and another one who harbored a somatic 630 mutation. And you see their disease significantly regressing with the neoadjuvant selpercatinib RET inhibitor, and allowing a better surgical outcome. And we now have a phase 2 trial that is enrolling for patients who have any RET alteration. So both medullary thyroid cancer patients or non-medullary papillary thyroid cancer patients with a RET alteration can get onto this study if they have bulky, burdensome disease in the neck. And this is led by Mark Zaffario. As of last evening, he told me that we have this trial activated at 4 sites, MD Anderson, Michigan, Hopkins, and Ohio State. We have now enrolled 18 patients onto this study. The majority of them have been MTC patients, but we have had a few with papillary thyroid cancer, and we've seen some promising outcomes. So turning our attention to future directions in medullary thyroid cancer, I still think we have a lot of work to do in identifying other mediators of tumorigenesis. As I said, we can see RET and RAS in our non-hereditary patients, but then in about 20% of our patients, we don't identify any driver mechanism. And so I think we need better testing to identify those. And then mechanisms of intrinsic or acquired resistance, what is really leading to this developing, and which patients have this or can be predicted to have this development. We need new treatments, better treatments targeting RAS mutated patients. I think this is my biggest problem. I almost wish that my patients have that RET mutation, because I know that I can have drugs that can target it, but the RAS mutated patients, we're limited to vandetanib or cabozantinib at this time. What is the role for next generation RET inhibitors in terms of efficacy, but also addressing these resistance mutations? I don't know, for those who know the game called whack-a-mole, when you're trying to take this mallet and hit down all these little moles that are popping up their heads, I feel the same way when it comes to these resistance mutations, is that we're finding these mutations popping up as we treat our patients, and where does that take us, and how far can we continue to modify drugs to be more effective at addressing these resistance mutations. Also, we need further studies and time to evaluate the efficacy and role of neoadjuvant therapy in our MTC patients. And then is there a role for combination therapy with maybe the multi-kinase inhibitor with a selective RET inhibitor that might allow you to decrease the dose of the kinase inhibitor and have more kind of targeting of the patient's cancer? And is there a role for other treatments such as immunotherapy? We do have a gestalt or a feeling that immunotherapy as single agent is not very effective in medullary thyroid cancer, given that it's not a very hot environment in terms of immune cells. But would it be more effective if you combine it with a multi-kinase inhibitor like cabozantinib or RET inhibitor? And also, is there a role for PRRT? So far, studies that have been published have been relatively small and with variable results, with not very significant responses seen, but is there something that can be optimized in the future? So I really do have a sense of optimism when it comes to medullary thyroid cancer, and I do think that the future is bright. So in summary, our take-home points are that in terms of poor prognostic indicators and patients in whom you really want to keep an eye on are those patients with the short doubling times, less than a year, if they have high-grade tumors. And I would like to see pathology maybe address this when they do the pathologic readings, because I do think it gives us a little added insight into their tumor biology. And also in those patients with a low calcitonin to CEA ratio. There are 3 drugs approved for progressive medullary thyroid cancer: vandetanib, cabozantinib, and then the RET-specific inhibitor, selpercatinib. I always recommend that you check for somatic mutations in patients with the progressing sporadic MTC, and then systemic therapy is reserved for radiologic progressive or symptomatic MTC that's not amenable to surgery or other focal treatments, or are refractory to other management strategies. And consider biopsying the progressive lesion if they're already on drug therapy, or do a liquid biopsy to assess for these emergent mutations and that might be conveying resistance. And of course, always consider clinical trials for those patients who fail approved therapies. I have to give a little plug for my Oncologic Endocrine Fellowship Program. As Dr. Brito said, we established this more than 10 years ago now. These are our illustrious graduates from our program. We currently have our 10th fellow, Dr. Sarah Hamidi, who came to us from University of Montreal. We just recruited Dr. Luz Castellanos as a pediatric endocrinologist to help supplement our growing need to address thyroid cancer in our pediatric population. But each of our fellows have gone on to excellent academic careers. And so if you have trainees, or even you yourself are interested, please direct your inquiry towards me. I'd love to talk to you about our program. So thank you very much for your attention today. And I'm looking forward to some questions.
Dr. Hu, that was a wonderful presentation. Thank you very much. We do have several questions already, so I will go through some of those. The first question is about the management of diarrhea, either coming from medullary thyroid cancer or side effect of TKI therapy.
Thank you. So we will use intestinal motility agents, so things like Imodium, Lomotil. These really are our workhorse drugs that we would initiate, and actually it's just kind of around the clock. Even some of our patients are tentative about constipation that might arise. And so using those when they have 3 or more bowel movements a day, and also doing a diary, logging their food, because in certain patients, they have certain triggers. So whether it's dairy for one person, whether it's vegetables with another, whether it's fatty, greasy foods for another, or spicy foods for another. So it can be variable amongst patients. And so they need to know what their triggers are. Additionally, in some patients, if they can't be treated with those modalities, then I use tincture of opium, which with small little drops, these are not habit forming. They can be very effective in quieting down that diarrhea. Obviously, if they're refractory to those medical therapies, I do recommend a GI evaluation, making sure there's no other GI primary issue like a inflammatory bowel disorder that might be underlying the situation. Probiotics also, but yes, this is a very difficult thing. And if they are refractory, sometimes we do have to think about any other method to debulk their tumor so that their diarrhea is better managed.
Absolutely. And there are many questions about the timing of somatic RET mutations, and also the type. You mentioned liquid versus progressive lesion versus primary. Can you guide us a little bit more on that?
Beautiful. So so obviously germline RET testing should be done for all. That's standard of care. You rule out a hereditary component, even if they say, well, I have no kids and I don't have any siblings. Well, knowing the germline RET mutation is very important to know if they are at risk for the other endocrine neoplasias, right? But if their RET germline is negative, I will reserve somatic testing in those patients who have evidence of disease progression clearly. So if their tumor markers are rising over time, I want to start setting the stage for understanding their underlying tumor biology so that I can figure out what I might need in the future. Or if they clearly have radiologically metastatic disease that may be stable now, but it might progress over time, because these patients, although some of them maintain an indolent progression, some of them could be indolent for years, and all of a sudden something changes and they become more progressive at a faster pace. So I don't do the somatic testing at the front end for all my patients. It is expensive. Some centers, some areas of the world, they don't have this available to do, and it can be very costly to the patients if there's no insurance to cover it. And in terms of which one, NGS testing on tumor specimen is really the gold standard, because sometimes with liquid biopsies that you draw blood and you do it either in your CLIA certified in-house or you send it out to some platform, commercial platform, the liquid biopsy may be falsely negative if they don't have a very rapidly or aggressive progressing disease. You may miss a mutation. So if the liquid biopsy identifies something, then certainly you can count on that and rely on it. But if it's negative, you still don't know if they have a somatic RET or other driver mutation. So hopefully that helps.
No, absolutely. With the new prognostic classification, the high versus low, in the past, the calcitonin was a way to guide imaging outside the neck. Would that change in tumors that are high grade, yet with calcitonins in a normal range or not that elevated? Would you do more systemic imaging? And if so, what would be the role of PET scan?
Well, Dr. Brito, I wish I had the answer based on any clinical trials, but we don't. So we don't have prospective or even retrospective. I think the high and low grade is certainly very interesting. And I think looking at some studies identifying that will be helpful. The report that I presented gave some early indication of the local regional recurrence and the distant metastases recurrence as being increased. So I think calcitonin and CA are still the initial markers that we have, but definitely my patients who have those high-grade tumors, I will be following them every 6 months. I might even see them every 4 months if by chance their tumor markers are still excessive and progressing in that short interval. There's just when you see enough of these patients, you just get a feeling that this is going to be a bad player compared with another. So I don't know how to say that in an objective fashion, but you know it when you see it, kind of a thing. But yeah, I think that tumor marker still is a very important area, but I think in those patients who have the very burdensome disease and their calcitonin is relatively low, let's just say less than 400, and their CA is high, over 100, that tells me that they might have a poorly differentiated disease. And so I'm going to be watching them very carefully. I would have already staged them just to make sure they don't have distant metastases. And there are some lesions that are nonspecific. I'll follow those.
Absolutely. And the couple of questions about immunotherapy. What is the role? You mentioned briefly about immunotherapy as part of the future, particularly with some of the poorly differentiated medullary thyroid cancers that do express PD-L1.
Yeah, I think my experience so far is that it has not added any benefit. We've had some patients who are on single agent checkpoint inhibitors in phase 1 trials because they were enrolling for solid tumors, and I did not see much effectiveness. I think that the idea of combining with a kinase inhibitor by maybe leading some regional environmental tumor inflammation, leading to some inflammatory immune cells to that region, and then giving immunotherapy, it might be potentially helpful. That's a hypothesis. I think we have the trial looking at lenvatinib with a checkpoint inhibitor in differentiated thyroid cancer, but we don't have a trial looking at that. We had Dr. Dadu, my colleague, actually collaborate on a study that was looking at SBRT radiation to a metastatic lesion and then giving immunotherapy. And in the few MTC patients who were enrolled, there was not much response. So I think the only way to address that question is really looking into developing a trial to see if there is any effectiveness.
Well, Dr. Hu, we wish we have another hour because we have many remaining fantastic questions. My apologies to the audience if we don't get to ask your questions, but Dr. Hu, thank you very much for your wonderful presentation.
Thank you so much for your time, and have a wonderful day and weekend. Bye.
Take care, everyone. See you next week. Bye.